And so we kind of and then we talked again.
Oh, the circular press. I guess I can't see it. VIPs, but you can. How about the other side of your how's like treating you? Pretty good. Yeah, so tell me a little bit about the evolution of all the brand stuff, how you studied your technique. We are just starting to be able to talk about intermediate to got a lot of they've got data now, they got raw stuff. They don't know what to do. More sporadic. Yeah. Is there anything in the budget that might give you guys a little more subsidy dollars to support this from that it's another year. Because across all of the agencies and sectors, great appreciation of programs of trying to redesign care and support social determinant related issues to find unlimited. We were well, right now that I know that, I'd like to especially funded students. It's moving in the right direction. In terms of at least understanding the language of how that I would have to get some I've always appreciated making really creative people, pushing that, really replicate. I'm going to get these agencies, first step right now is the transition to especially on our team right now. There's Margaret. There's more than that. I can see what does an agency really in your group of something cool. I feel that HPC territory to be conversations really have to decide that's really there's all sorts of politics whatever is great, you get a lot of support from doing stuff. More than this is today.
I can ask people to start taking their seats. We're going to get started in just a few minutes here. Well, good morning, everyone, and welcome to this special event hosted by the Health Policy Commission. I'm David Seltz. I'm the Executive Director of the Health Policy Commission, and it really is such a privilege to have everyone here today. This is a packed room this morning to talk about a really important topic. I do just want to say, please help yourselves to the food and coffee throughout this morning's event. That's what it's there for. This is actually our third special spring event. And for the HPC superfans out there, you may have been with us for the last two. 2 years ago, we held an event talking about the role of community hospitals and their future and their status, community hospitals at a crossroads. A year ago, in this very room, we held an event thinking about consumer preferences and what matters to consumers when they're making healthcare decisions. And these events, these spring events, are really an opportunity to convene experts, stakeholders, legislators, members of the public, and members of the healthcare community here in Massachusetts to discuss and engage on really important and timely topics of the day. And this year, we are so excited to focus on a topic of incredible increasing attention and consideration, both in Massachusetts and across the country, addressing the social determinants of health. Now, my public health policy friends are always very quick to point out that the idea that the behaviors, physical environment, economic factors, and social factors contribute to health is not a new idea, and that it has been well documented over time, and that healthcare policy, delivery, and the payment policy people are late to this party. Well, we're here today, as evidenced by this packed room. We're all here now focused and identifying solutions to these complex problems by connecting public health, social services, education, criminal justice, and so many others to the traditional healthcare system. With the shift to value-based payment and ACOs, it's clearly apparent that the healthcare system needs to identify solutions to tackle these systemic social challenges. The how and the who is less apparent, and one in which we hope to really engage in a conversation here today. This discussion is even more relevant and timely here in Massachusetts at the outset of our 1115 waiver. Under the thoughtful and visionary leadership of Secretary Mary Lou Sudders and Governor Baker, the Mass Health Program now includes nation-leading payment policies and incredible investments through the DSRIP program, the ACOs, and their community partners, trying to link together healthcare systems to community organizations to address the health-related social needs of residents across the Commonwealth. As always, Massachusetts leads the way, and our efforts here will surely inform the national conversation about how best to support healthcare providers to better address social determinants of health. Before we kick off today's event, I do want to recognize a few very important people in the room with us today. We have a few members of the legislature who are joining us. I know Representative Gentile is here, and we're expecting Representative Barber as well. We have Undersecretary Lauren Peters here on behalf of the Executive Office of Health and Human Services. Somewhere? Oh, hi, right in front of me. We have a lot of members of legislative staff. Thank you for being here. We really appreciate it. We have so many other government partners. I can't list them all, but members of staff from the Department of Public Health, the Attorney General's Office, the Connector, Mass Health, EOHHS, DMH, and so many others. We are all working together to tackle this issue. I also want to recognize a few of the commissioners of the Health Policy Commission Board who are here. Dr. Marty Cohen is here. He is the chair of our Care Delivery and Transformation Subcommittee at the Commission. Dr. Don Berwick, who we'll hear from a little bit later, is here as well. And former Commissioner Carol Allen is here as well. Thank you, Carol, for being here. Oh, and Paul Hattis as well, former Commissioner Paul Hattis. I also want to recognize there's a lot of members of the HPC Advisory Council. I can't even list you all by name, but you know who you are. Thank you for being here as well. And then finally, with any event like this, it takes a lot of work behind the scenes to pull this off. And so I do want to recognize a few members of the Health Policy Commission staff who were real leaders in putting this event together today. First of all, I want to recognize Katie Shea Barrett, who is the Director of Policy for Care Delivery, Transformation, and Strategy, really the thought leader behind today's event. I also want to recognize Kathleen Connolly, our Director of Strategic Investment, who oversees some of the investment programs that we'll hear from a little bit later, as well as the Deputy Executive Director, Colleen Elstenmeyer, whose team helps put this event off in such HPC fashion. Please, before we begin, just help me give a round of applause to everyone who worked hard. So for today's agenda, what we're planning to do and what we have prepared for you is a couple of speakers to kick things off, and then two separate panels. The first panel is going to focus on the practical and operational approaches to address social determinants of health, highlighting some of the Health Policy Commission's investment awardees and certified ACOs. And the second panel is really going to be focused on what is the policy environment that we need to create in order to continue and sustain these efforts. But to help kick us off, I am so pleased to introduce our keynote speaker today, Dr. Alice Chen. Dr. Alice Chen is joining us from San Francisco, where she's the Chief Medical Officer for the San Francisco Health Network. Her bio is in your programs. She is truly a national thought leader on this issue, and we could not have thought of a better person to be able to invite and to have with us to help frame and to provide some ideas for us and to really kick this conversation off this morning. So with that, Dr. Alice Chen, please join us. Thank you.
Excellent. Good morning. Good, you're awake. I may not totally be from Stone Calford in time. So, thank you. All right, it is such a pleasure to have the opportunity to talk to you guys about how to move towards a broader view of health, and actually to learn about what you are doing in Massachusetts. Just to give you a sense of the next half hour, I'm going to touch on some trends, give you a sense of what's going on in San Francisco. I want to spend a few minutes talking about poverty because that is ultimately the driver of much of this work, and share some reflections on where we can go. All right, so I feel like I'm ignoring that half of the room, but just know that I'm with you. Okay? So my personal entree into this area was in 1999. I was a third-year resident at the Brigham, working with Judy and Bigby in the Boston Public Health Commission. We did a hospital survey of what we were then calling non-financial barriers to care. Things like transportation, social services, access to like immigration, homelessness, and domestic violence services. Things that we would now call health-related social needs or individual social determinants of health. This is what we're talking about today, right? It's interesting to reflect on the fact that we call them non-financial barriers to care because we were so squarely focused on insurance coverage and the ability to pay for care, right? So we've come a long way, at least as measured by that gold standard of PubMed searches. If you PubMed search social determinants, in 1999 we had 249 articles. So to David's point, there's been a groundswell of interest. In 2013, we surpassed the 1,000 mark. And this year, we're on track to double that. So almost doubling in 5 years. And in this context, CMMI in 2016 announced its 5-year, $157 million initiative, Accountable Health Communities. And it was designed to test the hypothesis of whether systematically screening and addressing health-related social needs can decrease utilization and cost among Medicare and Medicaid beneficiaries. Right? You guys know about this. They chose 32 organizations around the country to implement this effort. But these 32 organizations are really just the tip of the iceberg. Really, in the context of ACA, ACOs, many healthcare organizations are starting to think about how do we think about population health? How do we think about health more broadly? And just in general, the top 3 areas have been food, transportation, and housing, right? Those are the things we talk about. So food. This is a pretty logical and intuitive place to start, right? It's pretty incontrovertible. The quality and quantity of your food is inextricably related to your health. It's interesting though, because even though there's this protean connection, aside from some really pioneers like Boston Medical Center, anyone here from Boston Medical Center? Hi, shout out. This is like a sister hospital, the San Francisco General, who started their food pantry in 2001 and is still growing strong, serving thousands of people a month. Most healthcare organizations really haven't paid attention to this until recent years. And I think it's partly because of research that's shown the seemingly paradoxical relationship between obesity and food insecurity and the cost of diabetes. People are starting to recognize that in America, 13% of American households are food insecure. 13%. 25% of African American Latino kids, food insecure. So there are some hospitals, Hennepin Health, Geisinger, who are starting food pantries, but most hospitals are screening and connecting patients to food resources. So transportation, this is a little bit more of a no-brainer, right? This is more aligned with their own self-interest. Given the state of public transportation in this country, it's no surprise people who don't have access to a car, less likely to make their appointments, less likely to fill their prescriptions. I think honestly, given the advent of rideshare companies like Lyft and Uber, it's also a little sexier and nimbler to actually dip your toe in the water, right? You can dial it up and down without making a long-term investment. But really the headlines have been around housing, hospitals investing in housing. And there's a reason for this. Last year, 2017, was the first time in 7 years that the annual federal count of homelessness increased. So across the country, homelessness increased by about 0.7%. In California, 13.7%. 13.7%. So it's much more visible. It's in the EDs. It's impacting our healthcare system. So you look up and down the coast in particular, Florida, Maryland, Massachusetts, certainly in California, Portland, you see hospitals contributing millions, if not tens of millions of dollars to address the issue of homelessness. And San Francisco is no different. So in many ways, we've been on the forefront in a lot of these initiatives to try to address health outside the four walls of the clinics and hospitals. So in 1990, I don't have a pointer here, but over here, 1998, we were one of the first cities to stand up supportive housing and a full harm reduction model, Housing First. 2002, we were one of the first cities to give out intranasal naloxone to avoid opioid overdose. At this point, anybody who's willing to go through a 5-minute training can get your Narcan kit. I have one in my bag. Anybody? Well, I can't give you the treatment. 2007, but just as a promo. 2007, we stood up our Healthy San Francisco program, which was our access to care program, regardless of pre-existing condition or documentation status. But what was different about this is it wasn't about just preventing you from going into bankruptcy if you access care. It was about actively reaching out to the uninsured and bringing them into care, assigning you a primary care home, getting you in for primary and preventive care. Just this year, we're ground zero for a 3-year, $6 million Medicaid initiative to test the value of therapeutic meals and avoiding hospitalizations, readmissions for congestive heart failure and diabetes. And we are among a handful of cities vying for the privilege, maybe, or punishment of opening up a safe injection site. While a lot of those initiatives have been driven by clinicians in our publicly funded delivery system who are seeing the need firsthand among patients, the truth is the reason we've been able to do these broader initiatives is because we're housed in a larger context. So this is our structure. In the City and County of San Francisco, Department of Public Health is the largest city agency. It has 2 arms. It has a population health division, which is the more traditional public health functions. You know, restaurant inspection, disease outbreak, vaccinations, public information campaigns. And then on this side is our publicly funded delivery system. And so in California, we still have these county hospitals. We have it's now called Zuckerberg, San Francisco General. You may have seen some of the controversy in New York Times, which is a level 1 trauma center and acute care campus. We have a 780 bed SNF. We have 14 primary care clinics, 25 mental health clinics, a whole array of substance use disorder services, jail health across 4 sites, maternal, child, adolescent health, and this transitions group is actually a special group that really targets the most vulnerable, people who are homeless, marginally housed on the streets, who are dually and triply diagnosed, trying to connect them to care. So that's our delivery system. We serve about 125,000 individuals a year. We really believe that primary care is the basis of our healthcare system. We have about 70,000 people actively empaneled into our primary care clinics. In terms of our demographics, you can see that San Francisco is primarily a white and Asian city, but we actually serve a disproportionate percentage of African Americans and Latinos. In terms of insurance, San Francisco is actually, because it's richer and has fewer kids, has a lower percentage of Medicaid. In the state as a whole, it's about 1 in 3 people in California are on Medicaid. San Francisco is only 18%, but for us, it's the majority of our patients with some Medicare, Medicaid, and some other public programs. In terms of other measures of vulnerability, the truth is we don't actually have great data, which is I think one of the issues that we'll probably be talking about, which we don't have a systems view. We have our best data around language, so about 35 to 40% of our patients are limited English speaking. The rest are really point-in-time surveys, cross-sectional surveys. For low functional health literacy, it's about 40 to 50%. Food insecurity is actually staggering. When you actually look at it, when you actually look under the covers, in primary care, 40%, up to 70% in our mental health clinics. In housing, in primary care, it's about 10% who are homeless or marginally housed, but I just got off 2 weeks on the inpatient service, 42% of our patients were homeless. So, we have many, many initiatives across every one of those divisions around social medicine, but I'm just going to choose one to tell you about a little bit in depth. So who here is familiar with the Bay Area Rapid Transit System? Who's written it? Okay, excellent. So I'm going to introduce you to Miss A.S. She's an 89-year-old woman, originally from Australia, no friends, no family, completely socially isolated. She was actually living on the Pittsburgh-Bay Point BART line. So every day she would get on, ride from Pittsburgh-Bay Point, go down to Millbrae, and go back up. At night she would get off the BART, stay on the streets, and the next day repeat. The problem is she was sitting there in her wheelchair and she'd be incontinent. And her alarmed fellow passengers would call 911, the BART police would come, they'd escort her to the nearest hospital. So in the year prior to our intervention, she had had 60 ED visits to our hospital alone. And that's not counting our sister county hospitals in Alameda and Contra Costa County, because this is the long BART line. So in February of this year, our ED social medicine team was on board and activated. They got called down. She came in with pressure ulcers, matted hair, had not bathed. They came and they sat down and talked to her and just said, "What are your hopes?" And she said, "I'm hungry, my bottom is sore, and I'm afraid that someone's going to steal my belongings." So they brought her a sandwich, some sturdy plastic bags, and were able to connect with her to engender just a little bit of trust for her to move indoors that night. And she's actually been sheltered ever since. She has healed with her pressure ulcer, she has an ID, she has Medicare and Medicaid, she's waiting benefits, and is on a list for long-term housing right now. Actually, as a twist, the EMS actually called around asking if she had passed away because they were wondering where she had gone. Yeah, it's nice to be able to tell them. No. So Ms. A.S. is actually probably not unfamiliar to people who work in urban hospital settings. Many of our patients are high acuity, others are high social acuity. The truth is the ED is not equipped. Its workflow, pace, volume are not equipped to take care of these patients. So when you're down there, you really have one of two choices. You can actually discharge with guilt and apprehension, knowing that they're likely to come back, or you can admit with guilt and relief. But now you have a lower level of care patient, you're dead, right? So really our goal, these kinds of patients are the ones that we thought we can do a better job here. And so we developed a multi-pronged initiative with the goal of decreasing our short-stay social admissions by 50% in 1 year's time. I won't go through all the countermeasures and PDSAs, but I just want to share with you the structure of our social medicine team. So what we did was we actually took the existing people. So we didn't add a lot of new FTEs. So we took people who are actually already working in the ED, and we said, we want you to huddle at every shift and not talk just about the medical issues and handouts, but also about the social issues. So we added one person, the patient care coordinator, who's the catalyst for this conversation and connector to these resources. If the patient is more complex, like Ms. A.S. was, we bring in the social MD who has a little bit of extra time, can sit down and really engage with the patient, has a knowledge of the resources, and kind of braid together a biopsychosocial plan. And then they link to our transitions team, which I told you about, who is essentially our community-based effector arm. They have a fast track into things like navigation centers, stabilization beds, shelter beds. And so then we work as a team to try to get those patients taken care of. And as a result, we've actually met our goal of avoiding more than 20 social admissions a month. And we're now in the process of expanding this. So, like I said, I actually had 3 or 4 different examples to share with you, but in the interest of time, because I didn't realize till later it was only half an hour that I got into an hour, I figured it would be more important to talk about poverty, because as important as these initiatives are, truly it doesn't address the root cause of why we need these programs. And so the federal government says that 12.7% of Americans are poor. Now, how poor do you have to be poor? Like as a single person, tell me how much income can I make and still be considered poor? Yes. $12,140 is the upper limit of being poor. For each additional member, $4,320. And you wonder, how do we come up with this number? How could it possibly be so low? Do you guys know the story? So in 1963, this is Molly Orshansky. She was a statistician and economist with the Social Security Administration. And this is in the context of the Great Society programs. And they were trying to figure out, how do we define who's eligible for these programs? And what she did was she took the Department of Agriculture's 4 food plans, the cheapest of which is the Thrifty Food Plan. And it's meant to be designed for temporary or emergency use when funds are low. And then she extrapolated from a household survey which showed that on average, American families spend about 1/3 of their post-tax income on food. So she costed out the Thrifty Food Plan, multiplied it by 3, and there you have it, the federal poverty threshold. It's been adjusted annually since 1969 by CPI, but not for any of the things that we know are driving costs. Urbanization, cost of childcare, transportation, technology, housing, none of that is accounted for. And that's why we are where we are. I just as a footnote want to say that, and she also wrote, if it is not possible to state unequivocally how much is enough, it should be possible to assert with confidence on how much on average is too little. And what I find interesting is that this poverty threshold has really been a way for us to exclude people from benefits over and over again. You have states who have Medicaid eligibility set at 25% of federal poverty level. What does that even mean? So we have the numbers, and then there's a narrative. So the numbers, we talked about the 12.7%, that's 41 million people. 95 million Americans live at 2 times the federal poverty level. And I just want you to think about this. This is income. But when you talk about wealth, the bottom 20% of Americans own how much of the wealth? 0.3% of the wealth. The top 20% of Americans, 84% of the wealth. So it's not just about income, it's about this generational wealth and kind of generational poverty. And for those of you who are surprised by these numbers, I'd really encourage you to read this report. The UN, it turns out, has a special monitor on extreme poverty and human rights. They are charged with doing country visits, doing interviews, analyses, submitting a report. Last year in December, they decided to choose the United States. So they went to LA, San Francisco, Alabama, my home state, Puerto Rico, West Virginia. And the stories are really sobering, even for those of us who work in the safety net. They also weave in some of the statistics. So it turns out that the United States, despite being the wealthiest country in the world, is also one of the OECD countries with the highest rates of poverty and income inequality. And our closest competitors are countries like South Africa and Turkey. So just to wrap up this, part about poverty, I think it's impossible to talk about poverty in the United States without talking about some of the policies that have really reified and racialized poverty for African Americans. We think about slavery, Reconstruction, Jim Crow as historical events. Those events have a very, very long tail. And so, for example, this is a 1937 map. The Federal Home Loan Bank Board commissioned these from the Homeowners Loan Corporation. There are 239 of these across the country, and asked them to indicate which neighborhoods were unsafe to make loans for. And you can see what the criteria were. And as a result, the neighborhoods in red, hence the term redlining, were actually ineligible for loans, shut out of homeownership, shut out of generational wealth creation. And so if you look at this current day map of poor academic performance in San Francisco, it's probably no surprise that it looks pretty similar. If you look at preventable hospitalizations, it looks pretty similar. I could give you half a dozen more maps that essentially have the same contour. In this day and age, right now, or 2016, San Francisco's median income was considerably higher than the nation's average, $96,000. For African Americans, it was less than half that. It was $46,000. So just generational differences in ability to engage fully with society. So this is a man who addressed racialized poverty head on. Who is this? Jack Geiger, yes. So he's widely known as the founder or one of the founders of the Community Health Center movement. In 1965, he founded one here in Boston, but then one down in Mississippi, one of the poorest counties in the country at the time. African American, 80% unemployment, rampant malnutrition and hunger. So they went down and he and his colleagues opened a clinic. But they also did community organizing. They dug latrines. They started vegetable gardens that grew into a 500-acre co-op. And they wrote prescriptions for food. And you may have heard this story before. So when the government officials came down and were asking, why are you charging food against the pharmacy budget? Jack Geiger said, last time I looked at my textbooks, the specific therapy for malnutrition is food, right? Pretty commonsensical. So fast forward 50 years, and we have really expanded on his vision. There are 1,200 community health centers are part of the fabric of our healthcare system. They're one of the only bipartisan issues left, right, in healthcare. People like community health centers, 1,200 of them, 9,000 access points, serving 27 million people. But what I would ask you to think about, even as we have expanded on his vision, we have radically constrained his vision. Because now if you want to open a community health center, it's not about community organizing or sanitation or gardens. It's about billable visits, your site visit protocol, and about reporting requirements. And lest you get confused in the maze of requirements, there's a small army of consultants who can actually help you navigate it. But I think what is most telling is that if we wanted to write a prescription for food, it would actually take a lot more time and documentation, and probably a couple people on the back end checking that your codes are right in order to get you that food. Remember Miss A.S., our lady on the bar line? Great. It wasn't that long ago. You guys said you're awake. So from our medical lens, this is her history of present illness. This is her history of present illness. And so don't get me wrong, having ICD codes for social needs in healthcare is actually a step forward. In the same way that PubMed, for us in medicine, is a way to gauge the significance of something, having an ICD code for something actually indicates that you've arrived, that you're significant enough that we are actually literally going to codify your importance, right? And at the same time, I wonder if we're losing something in this process, because think about how absurd it would be if we had to hire an extra person to capture the complexity of our patients instead of actually addressing their underlying needs. And the truth is we haven't really arrived, because think about it, homelessness has one ICD code. We don't differentiate between the fact that you're on the streets, in a shelter, in your car, or on a bar, right? And I can't help but share this with you, because I stumbled across this list of ICD-10 codes when I was trying to diligently capture my primary care patient's complexity. And you can see here that patients' intentional underdosing of medication regimen due to financial hardship, i.e. I don't have enough money to pay for my meds, is broken down by therapeutic class. Is it an antithrombotic, an antithyroid, a coronary vasodilator, anti-epileptic? The question is this the direction we want to head in this sector? And I don't think my fears are unfounded. So I'm sure many of you saw Ashish Jha's paper in JAMA earlier this year. He was trying to look at why do we spend 50% more per capita than any other country. He compared us to the top 10 OECD countries, and he really came out with 3 drivers. One is pharma. We spend about twice as much as other countries. One is salaries. So my salary, probably many of your salaries, doctors and nurses make a lot more in the United States than other OECD countries. But the last thing is administrative costs. So we spend about 8% of our healthcare dollar on administration compared to 1 to 3% for other countries. 8%. And this is a little bit deceptive. This is rate of growth, not actual numbers, but you can see that with every new well-intentioned initiative, the administrative infrastructure and need has grown. And there's a 2013 Harvard Business Review article that actually lays this out. They did an analysis of Labor Bureau data and AMA data. And for every one physician, not the physicians of the NLMBR, but they're a useful anchor point, for every one physician in the healthcare workforce, there are 6 other clinicians, like nurses, MEAs, therapists, clinicians, and 10 administrative people, whether it's clerks or finance people, quality people, important people. But I just want you to think about 1 to 6 to 10. Are we being intentional about how we're investing our resources, and is it value added for our patients and our communities? All right. I'm sure many of you have seen this before. This is Betsy Bradley's work, and her question was similar. It was like, why are we spending so much and getting not so much for our healthcare dollar? And her insight was that if you look at just the blue bars, which is the healthcare spend, of course we spend more than everybody else. But if you stack it with the social spend as a whole, so things like education, housing, employment opportunities, senior supports, we are not an outlier. We're in the middle of the pack. It's just that our priorities are different. Our values are different. So for other OECD countries, for every $1 spent on healthcare, about $2 is spent on social services. For us, every $1, it's 55 cents. And so I just ask you, what would it look like for us to shift some of this blue into red? I didn't actually mean those, but the political divide. But I mean, what if it was a little purple in the middle, what would that look like? And I think you need to go no further than the budgets of HUD and CMS. So between 1970 and 2017, the HUD budget increased by about 3.7-fold. CMS by 19-fold. So again, what would it look like if these lines converged a bit more? Have any of you seen this New Yorker cover? So I co-opted it because I actually think, I would challenge us to think that everything is not about us. You know, we in healthcare tend to think of everything through the healthcare lens. That's why Ms. AS has that, you know, HPI, that's a bunch of letters and numbers. Healthcare is not an end. Healthcare is a means to an end. Healthcare is what some people need in order to live a healthy and engaged life in which hopefully they don't use much healthcare at all, right? So really, I think reframing it, and I think since we're in Boston, if the New Yorker is not your favorite journal, there's the New England Journal. And this is from the College of Medical Care. It was first done in 1961, redone in 2001. And I'll just walk you through it. I'm using the old schematic because it's simpler, and remarkably, things haven't changed much between the 40 years and the intervening 40 years. So out of 1,000 community dwelling adults in a given month, about 750 will have symptoms. About 250 will consult a physician, 9 will be admitted to a hospital, 5 will be referred to another physician, and 1 will end up in an academic medical center. And you can think of this as public health, self-management, primary care in quotes, because in our ecosystem, you know, this could be the ED, it could be a minute clinic, it could be your specialist, you know, it's someone who's a first touch. Hospitalization, specialty referrals, and academic medical centers. And I think a lot of the conversation around health reform was in part driven by why do we spend so much attention and resources on this 1 out of 1,000? How do we actually re-equilibrate? And I think a lot of the efforts were really about at least pushing it out to primary care, right? PCMH, getting people, shoring up our primary care infrastructure. But really, I think we need to look beyond that and really think, how do we actually take a broader view? So there are no easy answers. I don't have solutions for you. I do think that one, this new, not even new, but this resurgence of interest in kind of individual level social determinants, larger social determinants, vis-a-vis healthcare is really important, and we need to sustain that. I think using levers like community benefits is really important, and it's completely insufficient. There are a few organizations, I think, that are thinking about this more broadly. So there are health enterprise zones in Maryland. They're talking about it in North Carolina. The one in Philadelphia, I think, is most interesting because even though they're clearly talking about Medicaid, high users, even though they're clearly talking about the spend, they're really leading with education, technology, community development. They're not leading with how much can we save in Medicaid, because ultimately I think that's too narrow a lens. And it sounds to me like this is more like a modern day Jack Geiger. And then University Hospital in Cleveland is really taking its role as an anchor institution very seriously. So looking at its employment policies, its pipeline, its purchasing power, its political power, to really think about how do we serve the community in ways that are not just about healthcare. And then lastly, in Oregon, the community coordinated care organizations, they're rethinking the next version. And I was talking with John Kitsaber, and they've actually been exploring this idea of taking what I think is just like a little bit of an odious term, the medical loss ratio. You know, how much you lose by spending on medical care. How can we actually transform that into potentially a health loss ratio, where you actually, over time, shift money from the healthcare system actually into the social sector? So I just want to leave you with 2 quotes that serve as touchstones for me, and I think are really relevant to this discussion. I'll let you read them yourselves. And then 3 last thoughts, which is our focus on identifying and addressing social needs is absolutely necessary, and like I said, utterly insufficient. We should really resist the temptation to medicalize poverty and social resource needs. I think the question is, do we have the commitment to health that would logically result in shifting money away from healthcare over time? And this asterisk is a reminder for me to emphatically say not just for poor people. This is not just within the boundaries of Medicaid, because frankly, Medicaid, although it doesn't even have enough money to pay for all the services it needs. So this is about a larger societal discussion and development of a commons. So that's the end. So I welcome questions.
So we have time to take 1 or 2 questions, and I'll let you get your thinking hats on, and I'll ask Dr. Chen when to start. So Dr. Chen, you know, we are your state health policy folks here. If you could change one state policy in the state of California to better support you in doing the work that you're doing in San Francisco, what would it be?
Actually, we were just talking about this. I think for our patients in particular, the roots are deep. Oftentimes I say, this is not answering your question initially, but like if you had a magic wand and you could take the 18% of GDP and actually just shift a lot of that into poverty reduction and early childhood interventions, I think that would be a much better use of our spend. That's not really within the context of our current day policy framework. I think mental health, the lack of mental health parity has driven siloing and funding for behavioral health, substance use, and medical care. And that's really where we're having a lot of challenges. In our last Medicaid waiver, we have a whole person care waiver, or a whole person care program. Many counties are focusing on homelessness, and I'm gonna walk over here because I feel like I haven't talked to these people well. That basically, it's really, really hard to integrate things on the back end if the front end in terms of funding, regulatory oversight, and reporting requirements are completely siloed. At the state level, these different agencies or sub-agencies don't even talk to each other. So we're actually trying to blend together care for severely mentally ill people with mild to moderate mental health, trying to create that continuum, integrating substance use disorder services into medical care, and it's really difficult. So I think the single thing right now would be to just figure out how do we integrate it, not on us, like not having the state have them be siloed and then say, you as a delivery system, go and integrate it, doesn't work. They really need to go up to the source and actually try to create some integration from the beginning.
In terms of integrating behavioral health care and physical health care, how do you deal with the implicit bias against persons with psychiatric challenges that results in them getting inferior physical health care if the providers know about mental or psychiatric challenges?
And that is again a decades long. The fact that we didn't have parity in Medicare until recently. For Medicare you had to pay 20% copay for physical health, 50% for mental health. We've built this bias and stigma and kind of lesser than through our entire system. With that said, in our system, what we've tried to do is create kind of no wrong door for our SMI population. So for primary care, we have primary care behavioral health teams that are embedded in, we have 70 FTEs across 90 clinics to do this behavioral health integration, and we actually try to link people, with not necessarily warm handoffs, but telephone handoffs to our SMI system of care in primary care if they show up there. We have telepsychiatry embedded within primary care. And then once you go over to the other side, in our mental health clinics, we've actually developed some health homes where we station a nurse practitioner as a satellite of our community health centers to actually provide physical health for those people who can't really bridge over into medical care. And then we actually have set up a reverse consultation system for our psychiatrists for those patients, again, who aren't getting their way into physical health, so to support them, because psychiatrists don't know how to treat diabetes, hyperlipidemia, hypothyroidism. So we actually have a reverse e-consult system where they can actually get access to primary care providers' expertise to kind of start medications, titrate them up and stuff. So we're trying to create, within this structural context, a no wrong door delivery system.
I'm actually, sorry, we have a last question right over here.
Quick question, Dr. Chet. Paul Hannes from Tufts University Medical School. How likely would you say that you'd be able to succeed even in convincing your own system to move, probably 97 or 98 cents on the dollar goes to the medical care side and 2 or 3 to public health, to make it something like 96 and 4?
Well, can I just tell you, so one of the programs that I was gonna, actually the supportive housing that I talked about that we started in 1996, that was funded by closing down the acute care unit. It was quite controversial. People were saying, our ED is overflowing. How can you take away acute care beds? But the decision was made that honestly, it's better to actually house these people and stabilize them than to have another unit full of these patients. So it's not easy. We have done it. We haven't done it to the extent we need to. I have these conversations with our CEO all the time when she's advocating for opening more beds, and I say, actually I understand the need, especially during flu season, but that is not the direction we need to go.
Do you sit on the medical care side, by the way, or is your job sort of over the theory vote pieces of the public health?
I'm just on the San Francisco Health Network side, but we do a lot of joint initiatives.
So that's it for time for Dr. Chen. Can we have one more round of applause?
Thank you so much. That was such an incredible and inspiring talk, and I think really speaks to the fact that I'm going to try to do the same thing here and kind of walk over a little bit. That really this is a national conversation, and we really wanted Dr. Chen to be here to highlight the fact that there are really innovative and interesting ideas happening all across this country, and I think it's really important, as much as I said earlier, Massachusetts leads the way, that we're humble and that we're learning from what other states and counties and cities are doing. I do want to also just kind of acknowledge that she mentioned Dr. Ashish Jha and that JAMA article. Dr. Jha is going to be our keynote speaker at this year's cost trends hearings in October. So encourage you all to mark that on your calendars later this year. She also highlighted that important study about the spend of developing countries on healthcare and social services. One of the co-authors of that particular study, Lauren Taylor, is going to be on one of our panels later today. But now we're going to really shift gears to talk about what's happening here in Massachusetts and what we can learn from some of the progress we're making in this area. And with that, I'm really honored and pleased to be able to introduce our Commissioner of Public Health, Dr. Monica Burrell. You can stand next to me while I say a few nice things about I think Dr. Burrell needs no introduction to this audience, but I will just say you have spent your entire career working and thinking about these issues and really recognizing and understanding individuals and their histories and how much that matters. And now, in your role now, translating that into how do we develop state policy to really address this. And I think one of the main areas of focus that you brought to the department is around using data and creating and linking data across all of the different data sets that you have at the department, as well as data sets across state government. And that is truly a groundbreaking work that will really contribute to the evidence base of what works and what these solutions are. So thank you for your leadership. Thank you for being here, and I'll turn it over to you for some remarks. Thank you.
Thank you. Hi, everyone. Thanks, David. Great topic today. Thrilled to be here among friends, and really also thrilled to follow Dr. Chen, who I'm so glad you could all hear from today. Is really a thought leader in this area. So as we talk about, so we went from San Francisco, and it reminded me of my days in San Francisco, so nice to have that connection. Now let's come to Massachusetts and talk about Massachusetts. And I will start by saying, where's David? David, I get really, I'm very enthusiastic about this talk. Just give me the hook when I know I have only a few minutes and we're behind. You may need to pull me off the stage. Okay, so here we are. I hope everybody knows this. Massachusetts was just ranked last year as the healthiest state in the nation. This is fantastic and really important. And there's a lot of people in this room who've spent decades, lifetimes worth of energy thinking about smart health policy, making sure we have access to care, and or, for some of us both, working in the healthcare systems, providing superb, high-quality healthcare. So thinking about how to keep people healthy, and then thinking about treating disease when they have disease. And this is really good. And as David said, we're so proud to be leaders. And this, number one, is an accomplishment that everybody in this room should be proud of because of the work we've done together. So what is our work now? Our work now is to say we're number one in the nation, but yet not everybody within this great state of ours is able to achieve the sense of optimal health and appreciate and benefit from our being number one. So I start, like Dr. Chen, I'm trained in internal medicine, primary care, worked for 20 years, mostly in and around right here in Boston. And my greatest lessons and how I think about policy today comes from my patients. So Dr. Chen also talked about neighborhood health centers. And I like to say my medical career was born and raised in neighborhood health centers. When I was a resident, was working at the Dorchester House Neighborhood Health Center. Anybody here from Dot House today? There you go, see? Oh, okay. That's good enough. That's good Go Dorchester. When I was at Dorchester House Clinic, I was a resident training at Boston City Hospital and Boston University, and I loved it. And I thought, wow, I'm like learning all these things, and I know all this stuff, and I'm really into prevention. And one day I had a patient, I mean, we're talking about 20 years ago, but I can remember her vividly, like she was sitting in front of me today. And I was going through it, I was saying, oh, you know, you have diabetes, your blood pressure's a little high, you're a little bit overweight, and these are the things you need to do. You have to start to exercise, and you know, you really got to eat these foods. And I was on. I mean, I was like going through the list. I knew the guidelines by heart. I studied them. I was at the front of the class, etc. You get the idea. And it was in the evening, and then she sat me down and she gave me the lesson that I needed. And she said to me, I'm a single mom. I have 2.5 jobs in order to be able to afford the rent, to be able to take care of my 3 children. I come home, I'm exhausted. I get food on the table that, by the way, I have to think really hard about what I buy. Because if I bought those fresh fruits and vegetables you're telling me to buy, I wouldn't have enough money to put a meal on the table at the end of the month. And you want me to go outside and walk, but the parks are not safe for me to go out at night after I fed my children, and so on and so on. You get the idea. And that was my awakening to, you know what, we all have social determinants of health, every one of us in this room. But to some of us, it impacts and hinders our ability to obtain this optimal health that is the #1 state all of our residents deserve. Some of us it hinders more than others. So as we talk today, I want us to think about my patient, because I'm going to frame our discussion on that. So, #1 state. At the Department of Public Health, our whole mission and vision is around helping individuals obtain optimal health. And that's about all individuals. And so when I came to the Department of Public Health, it was really important to me that we figured out how to frame this really consciously and very explicitly around equity. And getting to that, making all of us that #1 optimal state of health. So this is our Department of Public Health house, if you will. Our vision and mission remains the same. The red on the bottom is the foundation, the unbelievable people, both at the Department of Public Health and throughout our health system, who do the work every day. And in the middle is a little bit of what David was alluding to. We have a lot of data at the Department of Public Health. And the data sits in silos, just like many parts of our state government and many parts of the work each one of us do in our own silos. But people, as we know, don't live in those silos. So we have a lot of information that it is our responsibility to take that data, turn it into information that helps us understand better the social determinants of health and the impact of those determinants of health, and then to find the data disparities, if you will, and target our limited resources towards addressing those health inequities. So this has really been our focus for the last few years, and really a conscious way to think about equity for all of us in the room who care about justice and fairness in health. I want to take you back to my patient. So this is a heat map. So she lives in this area right in Dorchester. Maybe you should be my Dorchester point out person. So it's on the right-hand side of the map. And this is just looking, I use Boston as an example of a map. It's actually similar to Dr. Chen's points, you'll see in a minute. So this is looking at rates of chronic disease. And we know that rates of chronic disease are higher among some people. Let's dig deeper into the why and how. So this is the area that my patient lives in. This is the same map looking at for perceived safety, right? So remember I asked her to go outside and walk. So this is really important in terms of being able to access health. So same highlighted area in her neighborhood. This is looking at high rent burden. Remember my patient told me about the multiple jobs she has to have in order to be able to house her family. Same thing. And then this is looking at low access to healthy food. My patient living right in that area of the lowest quartile access to healthy food. Remember how she talked about stretching her money in order to feed her family. So that's my patient as a real person, and let's put it all together. So here's her high rates of chronic disease. Let's overlay that with, my mic's coming on and off, you all hear me? So, with the poor safety, and then add on the high rate, the high rent, excuse me, and then the poor food access. So that, you can see what happens and how this hotspot math shows as we look at, thank you. Hello? As we look at my patient's burden of her social determinants and how it impacts her health, the picture becomes clearer. That this is what she is impacted by. So all of us, again, are impacted by our social determinants of health, some of us more than others. So now let's go even deeper. What else is happening here? Well, in that same area where my patient lives, there's a high level of Black and Latino individuals living. My patient happens to be a Black woman, right in that same area. And then let's go deeper, because we've shown here from those last slides that place matters, right? Where we live matters for our health and our access to health. And race matters. Race in and of itself doesn't matter. But what does matter is racism. And there's all kinds of individual and other types of racism. But let's talk for a second about structural racism, as many of us are policymakers in the room. We didn't talk about our slides in advance, but we didn't have to, because this is that same redlining. So this was a national issue. Federal Housing Administration in the 1930s and 40s backing this. So again, remember that the yellow and red is considered areas of high risk mortgage, right? Going back to the 1930s and 40s, because we have to. That's where my patient now lives today. And this all affects her capacity to listen to my directions as the doctor in the room saying, hey, you should walk, you should exercise, you should, eat the right foods. So there's such an important role that healthcare plays, but we have to go beyond the capacities of healthcare in order to obtain health if we really want to do what we say we want to do, which is make sure that #1 state title that we have is achievable by everybody. So let's talk for a second. So moving on from this now, let's talk for a second. I do want to say one thing. When we talk about this structural racism, we say, well, we're talking about health here. How are you connecting this? Remember that all of these things really connect. If you dig deep enough, if you look at the data with a sharp enough eye and you focus, these things link together and are connected. And these policies, here's the good news, because this sounds really grim, I know. Here's the good news. The good news is that these things that we're seeing, these policies that were in place in the 1930s and 40s, they were made by people. And the good news is that we are all people who can change them. Okay, so let's talk now about the Department of Public Health. I'm way over time. Where's David?
Yeah, you're close.
I'm wrapping up. So what I want to give you in my last few minutes is just a little flavor of some of the work we're doing at the Department of Public Health that directly relates to this. I just chose 3 quick examples to give you, in the interest of time, but to give you a flavor. So the first one I want to talk to you about, and David alluded to this, was data, access, and translation. So let's think about data and the information that we have, and how can we make sure as we look at data, we look at it from all different angles. I'm going to give you a quick example of looking at the opioid epidemic. I don't have time today to talk to you in explicit detail about our response in the administration to the opioid epidemic, but as you know, it's the #1 health priority of our administration, and we see these skyrocketing rises and relieved to see a slight decrease. But one of the things that we did was we stratified the data and said, let's look at it in multiple different ways so we can understand it. And I want to just show you a couple of high-risk groups that we noted because of a different way of looking at the data. #1, individuals with an experience of homelessness. We found in our data that individuals with any experience of homelessness for any length of time had a 30 times increased risk of overdose deaths than others who used opiates. I want to make a couple of points about this. Dr. Chen showed you all the coding and how we can code for social determinants. With my work working with healthcare for the homeless for years, I have wanted us to better understand the way that someone's capacity of housing stability allows them to have health. And one of the most important things is we don't track it well. So what we did is we developed, that's why it says model, we developed our own modeling tool so we could validate whether someone had an experience with homelessness or not. And then we're able to come to this, which by the way, if you work with individuals with experience of homelessness, you already knew this clinically, but this puts a number to it. And I raise this point because many times we say, well, we can't do it. We don't have the data. We have the capacity. If you could put a computer in my hand, you have the capacity to be able to do this. So it's really about stretching and committing ourselves to understanding and finding the information because it's there, and now we're able to highlight individuals with housing instability in our work in the opiate epidemic. Second piece of the opiate epidemic here, these are our numbers and the devastating death that we're seeing. We see a 50% increase in white non-Hispanics, 52% in blacks, and when we stratify by Hispanics, it's 100% increase. So again, when we stratify in different ways, we can find different groups who need targeted attention. So think about using data to target in new and important ways. Second example is workforce development and community health workers. Many of you, like me, are advocates for community health workers being able to link individuals to their healthcare. Using our healthcare system is incredibly complex for all of us. Being connected to someone who can navigate through the system, who understands us and understands what our individual social determinants of health is critical. And I'm so proud that in July, we're launching our new voluntary certification program. And it's the first one to sit within a state's health professional licensure board. So we're really proud of that work. But another example. And my last example is around regulatory guidance and technical assistance. So I hope that everybody in the room can think about what their lever is. Because everybody here has a lever. And how can you use your lever to forward? We have to slowly improve the work that we're doing. One of the levers that we have at the Department of Public Health is our regulatory lever. So when we were redoing the determination of need regulations, we said, how do we make sure that those determination of need regulations help forward our public health goals? How do we work to balance the individual needs of the systems to provide good health value with our need to meet the health priorities of our state? And so when we redid the regulations, we really focused on the community health investments, right? We talked in our last talk about shifting funds. These are funds that are already going to the community. How do we focus those on the social determinants of health? So we really structured the process so that they do focus on that. In fact, we highlight the social determinants of health, which I don't need to go through with this crowd, saying that the community health investments must connect to one of these areas. And then we looked at the data and we said, what do individuals in Massachusetts die from prematurely? And what is their increased morbidity and high disparities? And these are the 4 areas we asked as health priorities for groups to focus on, for healthcare systems to focus on. And that is mental health and wellness, substance use disorder, homelessness and housing stability, and preventable chronic disease. So an example from a regulatory arm, how we are using our lever. So I hope as you continue through the morning, it's a fabulous list of speakers. I'm sorry I can't stay, but I hope you think about your levers. There's a lot of work for us to do here in Massachusetts, but as the #1 healthiest state, I'm confident that we can work together to achieve our goals. Thank you for having me here and for allowing me to go over time.
Thank you so much, Dr. Burrell, and of course you can go overtime anytime. Really do want to thank you for your incredible leadership. I also want to recognize Representative Christine Barber, who is here and joined us today. Thank you so much for being here as well. Both of the speakers this morning talked about healthcare as not as an end, but as a means to an end. And Dr. Burrell mentioned the need to go beyond healthcare and thinking about how we connect and use these different levers. And so our next panel is really going to be focused on how are some tactical and operational ways that organizations here in Massachusetts are linking, are connecting. And in the interest of time, I said Dr. Burrell needed no introduction and then gave an introduction. Dr. Don Berwick needs no introduction, so you're not going to get one. Go ahead.
Thanks so much, David. I'm Don Berwick. I'm proud to be a commissioner and senior fellow at the Institute for Healthcare Improvement, and an amazing turnout here. Thank you all for being here. We have a real treat ahead now. There's a quote from Goethe that I really like, which says, knowing is not enough, we must act. Willing is not enough, we must do. Now you're going to hear about acting and doing in response to the amazing call to arms that we have from Commissioner Burrell and Dr. Chen. I wish we had a lot of time, we don't. So panelists, I'm going to ask you to very briefly introduce yourselves, say a word about the project you're doing. And what I'd like you to do as we go down the line is introduce yourself, give maybe a half-minute description of the project, and then tell me what you're proudest of that you've accomplished. And we're going to have some time for dialogue then, so we get into some of the details. What you're hearing here now are actual projects that are supported through 3 programs: the Chart Investment Program of the Health Policy Commission, the Healthcare Innovation Investment Program, and the new Accountable Care Organization Certification Program. And these are some best practices for those programs. So panelists, welcome. Say a word about yourself. Tell us a word about what you've done and what are you proud of. Thanks.
I didn't have microphones. I didn't know. My name is Selena Johnson. I am. Can you hear me now? Yes. Excellent. My name is Selena Johnson. I am the project manager for Chart Phase 1 and Phase 2 with Haywood Healthcare. We are a 2-hospital unit in North Central and North Quabbin region. We partnered with Gardner Public Schools specifically to address access to behavioral health care for youth. We kind of live in a desert area that has very limited resources. So we wanted to be able to identify need and to support youth access to behavioral health care. I think one of the key things that we learned was that you cannot address just the youth in their need for behavioral health. You have to look at the whole person. Beyond the whole person, you have to look at the whole family. You cannot expect to make one impact without doing a ripple effect and having it last long. I think our proudest achievement with that is we're learning and we're seeing some change in how our entire system is viewing access to care and supporting patients.
I'm Mark Pellegrino. I'm the superintendent of schools at Gardner. We've worked with Selena and Haywood Healthcare to run the Chart grant. I think the thing that I'm most proudest of is the healthcare coordinator that's based in each one of the buildings has really shown us what a need this is, and we're now publicly talking about it. Our population has changed drastically. Our high needs population, our rate of poverty was around 15% in 2003, and now we're over 60%. So just to bring that out and to be able to put money behind the resources is an important thing for us.
60% poverty rate. Yeah. We're going to dig into this a little more. I'm going to come back to each of these panelists and help you understand a little more exactly what they've done. This is a partnership between the school system and Haywood Health. Let's go on to the next pair and describe a little bit what you've done and what you're proud of, please.
So I'm Kathy Moss, the Behavioral Health Network in Hampden County, and we are here representing Project FIT, which stands for Families in Transition. And this is a program that looks at supporting families where there is housing instability and some member of the family has an unmet behavioral health need, either mental illness or substance use, and it can be a parent or a child. And we have clinical care managers who are master's level behavioral health clinicians, nurse care manager, and community health workers who are trained with behavioral health, working side by side with our housing partners, school partners, primary care partners to address the whole family and get them the needs, get their needs met. And I would say what we're most proud of is the family systems approach, is that we're looking at families who are homeless, which helps the adults and their medical needs, medical costs, but also by hopefully reducing the toxic stress impact on the children, we hope to have a very long-term longitudinal impact on them as adults and their health care.
Hello, everyone. I'm Israel Ortiz. I'm the Director of Residential Programs for Wayfinders, Inc. in Springfield, Massachusetts. We partner work with Behavioral Health Network, and they integrate families in transition to partner with us to help our families get stabilized and hopefully sustainably housed.
So a partnership focused on mental health needs between Behavioral Health Network and the Wayfinders program in the community. Great. And our third panel from Lawrence, can you introduce yourselves and say a little bit about your project?
I'm Robin Hines. I'm the Vice President of Care Continuum at Lawrence General Hospital. I'm also the Vice Chair of the Mayor's Health Task Force Executive Committee in the City of Lawrence. With very closely, Vilma can explain a little bit more about that. I also sit on the Board of Directors at Merrimack Valley Accountable Care Organization, which is a certified HPC certified ACO that just started in March between us, Lawrence General, and Greater Lawrence County Health Center, which is a federally qualified health center in the city of Lawrence, as well as working very closely with Neighborhood Health Plan in a continuing partnership. Our project really focuses probably on the collaboration between the city and the population health needs of the city in conjunction with our community health needs assessment. And I think mostly what I'm proud of is really fully that collaboration and that ability for us to really work across any lines. I was talking earlier about saying that, you know, we're pretty scrappy in the Merrimack Valley, and we have to be. And so I think we think about innovative ways to work with one another that isn't always traditional. And I think you'll hear that a little bit more from what we've been doing.
Good morning, everyone. My name is Vilma Martinez Dominguez. I'm the Community Development Director for the City of Lawrence, and I have the pleasure of coordinating the Mayor's Health Task Force, which is the Health Coalition, also Community Health Network Area number 11 for the Department of Public Health the last 8 years. So this is the new role for me. And a perfect role. So you heard about policy and all the changes. My brain was really spinning. I think that a lot of the work that the task force does, it's a coalition that really promotes health equity, advocacy, networking, capacity building in so many ways. And so we are an organization that has about 80 member organizations across the state, and actually some of them are national members. And we do our work with working groups. We do our work really with the lens of social justice and health equity, really looking at, it doesn't matter which working group, what work we do, it's done with that sort of root cause approach. And so that is what's unique about us. What we're most proud of, I mean, we've been around since 2002. There's a few things, but the spirit of collaboration that Robin talked about, it's definitely something that you see there. We overlap in so many tables, so it's important so that we're able to align the work, align the resources, and really understand our community in order to create initiatives that make sense. So we're really excited about that. But we're also just institutionalized our Mayor's Health Task Force under the Office of Planning and Development, which is really neat, because now we're able to do so much more. So thank you.
Congratulations on what you've done. I want to dig in a little deeper on exactly what you have done. You're coaches to people in this room, so what I'd like you to do is explain a little more precision, some steps you took, something you actually did to help your projects go forward, as if you were teaching this group about how to follow in your footsteps. Before that, I had a chance to talk with people by phone in preparation for this meeting, and I want to go one step further about the level of need, because that's what blew me away when I was talking to this. Mark already said 60% poverty. Can you, each of you, we're going to have to be really short in your comments. I'm so sorry for the time pressure, but you know, when you think about the level of need, Mark, you were telling me about the number of kids in the school system that need mental health services and the kind of support you're offering. Can you say a word more about the magnitude of need? The others, get ready to do the same for your own setting. Thanks. It might work better if you undock the microphone, because you really have to hold it close to your mouth in order to have people hear you. Okay.
So our level of need, when we started this program, we started with one care coordinator in the high school. I was actually the principal at that time of the high school, so I worked very closely with Renee, our care coordinator. When we first started, the first thing we said was we need to look at the data. How many students are actually in need, to show that we have this need, so we could actually secure the funding and continue the funding. There was just an overwhelming number of students, so we were looking at, we needed 15 or 20 or something to actually show that we have some need. we wound up with, we have about 700 students. We had 150 or so students in the school who actually needed these mental health services. Right now, we have 17 counselors in the school that come in from different organizations, community organizations. So our students are having this need met within the schools, which I think is one of the most important things, because the level of transportation, their ability to be mobile after school, they're not getting the services at home. So to be able to provide this within the school day was paramount.
150 and 700 kids really need these services. How close are you to meeting the need now? Is there a big gap? You feel you show up every day feeling overwhelmed, or like you've got this under control? What does it feel like?
I feel like we're under-identified, actually.
Under-identified? There are more than those.
Absolutely. What winds up happening, though, is we also have, I don't know how to say this, we have a police force who also is working with many of these students, and they're going in the other direction. So we're trying to identify these needs earlier. We had 3.5 coordinators throughout the district originally. With these coordinators, we're trying to reach them in elementary school so they get the services as they're coming up. Because what we find is by the time they're in high school, it's late, and it's very difficult to catch up with those services. And there's still a stigma around receiving the services at the high school level.
So Selena, what does it look like from the Haywood's point of view? The need that Mark's talking about. Are you responsible for this, or is it like like you're being generous, helping others do something? Is this your work or not?
So the schools and the health center, we share these families. They're the students, they're our patients. And together, I think the community always looked at either the healthcare system or the school system to fix something. Who else is going to do it? So we are not new to partnership. The schools and health centers have talked often on how can we address something, how can we work together to make an impact. And we identified that if a student is having a hard time receiving services because of transportation or access or insurance, or that guidance can only do so much, referrals can only go so far, families will only take so much on paper when they have everything else in their life falling apart around them. Same thing with the EDs. We can only do so much when a referral is happening very simply, and that was the old style of care. Now we look at how can we work together and ensure that not just the student but the family is engaged and supported and directed and helped and advocated for, because if we can't help the family stabilize a bit more, the students cannot stabilize. So together we're looking at what kind of services exist in our area, what are the opportunities, where are the gaps, and we're much more aware of those opportunities and gaps now. But Mark hit it on the head. We are just scratching the surface. We're dealing with those that are in more immediate need. We have a very high level of complex care, not just for the student, but for the families. And that level takes a lot of work. So we're not even delving into the secondaries, the ones that could have some basic supports to get them on the path and to keep them connected with school. The whole purpose is to align their health so that they can stay in school and learning, hopefully graduate, and then become a successful adult in the community again.
It makes me wonder, don't need to respond at this point, but that these migrations out into real community needs, such as Dr. Chen was talking about, it's really opening a box, because you're just a 60% poverty rate, 170 kids identified, and even more. You've got to have some courage here to get into this, because you're going to discover more need than you thought of at the start. Catherine and Israel, can you talk a bit about this from your point of view in the behavioral health world, and being a pediatrician, I've got to ask you a little more about the need, especially with respect to toxic stress. You might want to say a word to people that don't understand what that refers to.
Okay, sure. So just in terms of the need, we had originally started with expecting about 140 families over the course of the 18 months of our project, and we've blown that out of the water. We've got referrals for well over 200, and we have 70 people still on the wait list.
What's the denominator there? What population?
I'm sorry?
What's the denominator population? 240 out of how many potentially that could be?
I have no idea.
What's the whole community?
All of Hampton County. So we
all
serve,
wow.
Springfield and Holyoke primarily, but all of Hampton County is where we're getting our referral base from. where we're getting our referrals from. We had started with a staff of one. We had anticipated a staff of one clinical care manager, behavioral health clinician, and two community health workers. And we've been able to shift some funds, some things around, and we now have 3 clinical care managers and 6 community health workers, and who are working really hard to meet the need. One of the things that we learned in the process for people who do this kind of work is that it's not your mother's mental health care anymore. It's not how we used to do care. So our inclination is when we get these wait lists, we have all these people waiting who really, really need the services, is to take higher caseloads and work with more and more people all at once. And then you dilute the model. Because this population and this kind of work, you need to have a very low caseload because it's very, very frequent touch, very, very high touch for this population.
Dr. Moss, describe a kid. What's one case that pops to mind that gives us a sense of the kind of people you're trying to help here?
Great, and I would say, I was thinking about this earlier. I think the population that we work with falls into 2 buckets, if you will. One is where the people don't know what they don't know, and they need education in order to get the services. So a family that I'm thinking of is a young mom who has some cognitive limitations as well as behavioral health diagnoses, and had a 2-year-old who we found out after we got involved with the family was having seizures. And the mom was actually diagnosed with autism. The mom didn't know she had a family member who saw the kid having seizures and said, I'm a PCA, and this is fine, you don't need to worry about it, and wasn't doing anything. They had no primary care. The mom almost had no teeth because she had no dental care. She just didn't have the skills and the resources. So our job with her was to educate her. We got our child evaluated, we got him into early care, we got him a pediatrician, getting well visits, we got the mom to get into primary care. And of course, we got her into therapy as well as referral for DDS services for herself and for her child. So that's an example of a family. The other bucket are people who know, but their own mental health and substance use are preventing them from accessing the care. And so that one is more about where we need to spend significant amounts of time working on engagement and connection. So because of their own history of domestic violence, which is hugely prevalent in this population, most of our families have domestic violence histories. All of our families have trauma histories. Of course, depression, substance use, anxiety, as well as some that's more severe mental illness are the people that we serve. Our staff needs to really work with them from a perspective of motivational interviewing and trauma-informed care to address the ambivalence, meet them where they're at, and help them resolve whatever the barriers are emotionally to trusting the service system and engaging in some of these treatments. Does that help?
Yes, it does. Mr. Joseph, so describe it from your,
from my perspective, and we team with Behavioral Health Network and Families in Transition. And, in my shelter portfolio, I have over 204 family units within our portfolio.
They're in the shelter.
They're in the shelters, and these are families, so you multiply that by an average of about 3 individuals per family, and we're talking about 500 to 800 people in shelter, and about 80% of those families or people need some type of health care, be it mental health, substance abuse, identifying disabilities with their children. And it's so important to partner with agencies like Behavioral Health Network in order to, on the front lines, really assess these individuals and make sure that they get the access to health care that they need in the long term. Really work towards stabilizing the families and positioning them into a sustainable housing situation.
So, Mr. Tisha, you said the magic word is important to partner. Why is that important?
I think for us, from my perspective, my agency's main mission is to house families, and so partnering with Behavioral Health Network to go out and assess and address, on a one-to-one basis, the family's needs, and then having the ability to, provide resources to families is critical to our work in that it allows us to work towards housing and stabilizing these families.
You could have taken a different position because if we do housing, we don't do care, not our problem. You didn't do that.
That's exactly right. And some housing agencies don't have the privilege to work with the Behavioral Health Network. often find themselves in that same situation because we have quotas from the state that say that we have to house so many families each month. And so in order to receive funding and in order to continue our mission of housing families, we have to meet those quotas. And so that really puts us in a position of really focusing on that.
Thanks, Dr. Moss. You have a comment?
I want to say one more. How could you tell? I want to say one more thing about that, which is that very often, and it's true with the housing partners as well as medical partners, is that they'll say, you need to do this. And of course they're saying that, right? That this is what the family needs to do in order to get sustainable housing and permanent housing. But it's just not that easy. And so the partnership is also about us side by side with the residence coordinators saying, what are the barriers? Why? What do you need to do differently in order to engage the advice?
Okay, I'm going to ask you, I'm warning you when I come back down the line
Okay.
about this partnering ideas. Because, you know, when resources are limited and the load is overwhelming, one other response is to circle your own wagon and say, I don't have time to work with you. I've just got to get my work done. And each of you has overcome this and spend energy to make the relationships. Let's explore that. But let's go back down to Lawrence now. Here we have a hospital and a mayor's office working together in a well, new way maybe.
Sorry.
Again, uncomfortably close to your mouth is the only way these people can hear.
Okay. Uncomfortably close. Okay, that's uncomfortable. All right. So I'll probably let Vilma probably describe really this because she really has been the focal point of the Mayor's Health Task Force and really has brought it to light in the city and really has worked for many years on it. But I think the way in which we had gotten involved originally, actually at Lawrence General, was we had a determination of need funding that really connected us at the level where I think there was need for the Mayor's Health Task Force to continue the sustainability it had already created within the city to really look at ways in which it can deliver health and population health attributes to the city's inhabitants. So, but the big thing I think also is the way in which how we identify, the Mayor's Health Task Force identify need is really through the community health needs assessment that's done every year. And being in Lawrence, you know, we come from an area where it's underserved. It's the probably one of the most poverty-stricken areas in the state of Massachusetts. And so, most of the healthcare entities are safety net hospital, federally qualified health centers that really deliver care to that underserved population. So we actually partnered with the health center this past time to do our community health needs assessment. And the things that came up, which we weren't really surprised of, is more on behavioral health needs, mental health needs, drug addiction service needs, chronic disease management, obesity, diabetes, and really healthcare access. And so I think this really just kind of really brought to light all the work that we've been doing for a long time and really married it all together. And I'll let Vilma describe that a little bit more.
Thank you. So I think that many people know Lawrence. It's an immigrant city. It's an old mill city. I mean, we have our own challenges. It's a gateway community. We have a lot of people living in a very small space. So we have about 80,000 people living in less than 7-mile radius space. So you're talking about 11,000 people living per square mile. You look at that and you look at poverty. I have to paint the picture for you. You look at poverty levels at 28% with an unemployment rate of almost 8 points. So this is just some things, but we also have a very young community. So the median age in Lawrence is about 31. And the population under the age of 18 is probably like 20, I think it's 24%, 25%. Chronic rates, high rates, we're primarily Latinos, primarily from the Caribbean, but we're seeing other communities there. And you look at teen pregnancy, you look at all these health indicators, right? There's health conditions. And then you see whatever you see in the newspaper, right? Because they don't depict us as the most positive community, but you have to understand this. I've been in Lawrence 25 years. Lawrence has a spirit of activism, a spirit of collaboration, this resiliency, this sense of community that we choose to approach the work that way. We approach it in an asset sort of based manner. With this, you didn't know probably that Lawrence in 2015 was one of 8 communities around the nation who won the Culture of Health Prize award from the Robert Wood Johnson Foundation.
It has been the most applications they have ever received, over 340 applications. So that means we're doing something right. And so I choose to go that way. And with that, the task force started in 2002. It was really an effort of the local government partnering with the health sector, saying, okay, if we don't have a healthy community, we'll have nothing. We have no city. At that point, it was born, and I've been a part of it since then, all the way till now. So we have been doing the work. And what was really interesting is that we had a lot of shovel-ready projects that came from the input of the community, the pulse. We know about the chronic diseases, we know about all these things. But what we didn't have is a strong infrastructure. So what the DON, by the time the DON partnership came about, we already had a sense of this is what we need. We just need the money and the bodies to implement it. And so we have been able to really strengthen the infrastructure, get a manager, it's going to be soon a manager, get like fully like a department within the Office of Planning and Development, because guess what? A lot of the work that happens in silo was happening already in the office. It took me 4 years to make people at the Office of Planning and Development understand that health is in all policies. And to start looking at complete streets and to start to look at green communities, how do we marry all these things together and create a momentum? And so we have been able to do that. But the other thing that we were doing is we had at one point 11 working groups. We couldn't do the work. And so through this strategic planning that we use some of the money for, we chose 5 areas based on those community health needs assessments. Those are homelessness, it's a major issue, which is related to substance use. We have one group that focuses on adolescent health and teen pregnancy. We have a group that looks at healthy, active living, really access to food, food justice, transit. I mean, anything you can think of, we're looking at through that healthy, active living, and the SALSA campaign, which is supporting active lifestyles for all. We're looking at really behavioral health because it's a major issue. And we're looking at research because we don't have the capacity to do the data collection. The other thing that this DON funding is doing is providing us an opportunity to hire people. One of them is a resource development team that's going to look at capacity building as we look forward, as this money, sort of goes away. How do we sustain it? And a data analyst that we're just looking at right now. So to teach us how do we collect data and interpret data in a way that makes sense so that we can communicate that to legislators and funders. So I think that's it. I want to stop here. And
Thanks, Will. Oh, well, okay, so don't stop yet. Robin, so Bravo Mayor's Office winning awards, the mayor has no choice but to think about the whole community. Lawrence General does. You're a hospital, you could say not our business. Again, that, as I was asking here, why are you doing this as a hospital?
Well, because it's our community, and and really we're the community hospital, and that is where people access care, and it is our responsibility to partner to really provide that care, and really take care of a population as a whole.
Is it in your business plan? I mean,
Yes, population health is one of our strategies. We have 5 major strategies, and population health is one of the large major strategies.
Because you think you have a duty, or because you can make money on it?
I think, well, we don't really make money. just saying.
Just saying.
But we know that with population health, obviously, it is moving from that volume-based world to that value world, as we know, right? And we are being forced into that. But I think it goes further for us in the terms of really looking at how to care for people and adequately provide the needs that people, require within the community.
Okay, so you listen to Alice Chen, you really understand this cannot be done without cooperation across boundaries that normally are tended instead of crossed. You have 3 examples of the word is partnering, that's the name of this session. So my next question, we'll go down the line one more time, is what's the glue? Like, is it that you got the money? Or is there, and feel free to be, it doesn't have to be just technical, there can be something emotional here, but what is keeping you together? Can you?
I would say first off, synergy. With the school system and the healthcare system partnering together, we don't know the things that they know, and they don't know the things that we know. We've been working on equity for a long time. Equity is actually the driver of our entire school system. So when we talk about race, when we talk about poverty, we've been doing that for a number of years now. And the healthcare system knows how to work with the health part of it, and we think of the growth of the children and the education of our children. So together, we've started some models that work pretty well. And I think the hard part for us is we don't understand the money as well when it comes to the healthcare providers for children. So what's happened is we had 3.5 care coordinators in the district. We lost a great deal of the money, so I took on 2 of the coordinators right under my budget. This year, we lost the funding for the one at the high school, which serves half of my population. So when I said we had about 150 students that are participating at the high school, well, in the district, we have about 300 students. So we're working a lot to make sure that these services stay in place. When I took over those 2 counselors to come into the school budget, we now are funding, and Haywood Hospital was able to figure out a way where we could have a fiscal agent to fund the 2 positions, and it was very difficult. Now we're looking at, I'm going for a 2.5 override in my district, which we're one of 17 districts that's never had a 2.5 override for anything in the city. And we're looking at losing the care coordination again. So we have the counselors coming in. We have over 30 counselors in the district that are coming into all the different schools, but we now can't fund the coordinator who does all those other things, making sure that there's heat at the home, making sure that they have access to food, all of those different pieces. So it was actually with we were meeting the other day, and one of the vice presidents said, there's a way we can actually start to access the Medicaid money with the counselors. So going into next year, we have to figure out a new model because this isn't sustainable for us. So we're actually going to be tapping into the next level of partner, which is the actual organizations that are sending counselors into the buildings so we can tap into their Medicaid money, so then it's a sustainable model for us. And I would have never thought of that.
We don't know what they know, and they don't know what we know. That's an interesting framing for partnership. What would you say, Selena, about the glue?
It was a great answer. It's hard to follow that one. I think he's right. I think the glue is that we are 2 organizations that care a lot about our community and see the need. We also see the challenges and the issues, and we're working in our silos, trying to figure out how to do it ourselves. And the truth is we can't do it alone. So together, looking at how can we link, what can we merge, how can we blend, so that we can provide these services and this care. Unfortunately, what we call the school-based care coordinator, that's our poster over there if you want to check us out sometime, is basically the equivalent of a CHW. And that person is not providing the clinical services, they're linking the services on site at the school, but that person is the bridge for everything else within that family and the community. So the glue is how can we all make this work so that we don't lose the momentum that we've had, and our passion is ensuring that there's access to care because it's our community.
Okay, so
we're really short on time.
You said earlier that we don't. Why are we partnering? We could easily say I don't have time to partner, and my answer to that was we don't have time not to partner.
We don't have time not to partner.
Right. And so I would say it's partly a mission decision. The glue for us is partly mission, partly business, partly funding.
Explain the business part here. Why is it necessary to do it in order to be successful and sustainable?
So if we're partnering with the housing resident coordinators, we don't have to help the families with applying for vouchers. We don't have to take them down to see apartments. We don't have to train them in financial literacy so that they can learn to budget and pay their bills. We don't have to do any of that. We can work with them on understanding how their anger affects their relationships with their neighbors, which prevents gets them fired, so then they don't have an income. And we can work with them on how to understand their triggers and avoid those and get into treatment and all those other things. So that's a business decision. I do have to say one more really quick thing, which is that one of the great benefits of this program has allowed us to support families for whom fee-for-service billing just isn't working. So I think that's when we talk about why we have a great system of care in Massachusetts for children with mental illness and families with substance use. The CBHI services are wonderful in terms of care coordination, wraparound, blah, blah, blah. But the problem is if they only get paid when the families engage. And so many of these families aren't ready to engage. And so there's a huge piece of this that the partnership allows us to find those families, and from the perspective of housing, allows us to be there again, be there again, be there again, be there again. Sometimes it takes 6 months, 15 or 20 touches for a family to say, okay, yes, I'm willing to open the screen door and let you come in and talk to me. ICC would have closed them years ago. We've had so many of these families referred over and over and over and over. Nobody owns them is a terrible way to say it. Nobody is walking their journey with them. And so if they're not ready to walk with us, we walk away in traditional behavioral health. A program like this allows us to walk along with them at whatever pace they're ready until they're ready to sign on the dotted line for more traditional services.
That's amazing.
I agree with Kathy as well. I just want to add a piece to that is that on the back end of the service, even after we place families into sustainable housing, they continue to see the families regardless, as long as we have funding. So I think that one of the best things is the synergy that we have in doing that, and also, as Kathy mentioned, just the funding to continue to get that. It's really critical in long-term sustainability. So many times we have families go out of shelter, and then within a year they're back.
So it allows a continuous relationship that you couldn't otherwise manage to forge.
Exactly. Thank you.
Thank you.
I think the glue that keeps us together is the fact that really most of the organizations, as we said, serve underserved people, and most of the organizations are disproportionate shared, like hospitals or health centers that really are under-resourced. And so I think what that keeps us going and really keeps us on target is really, tapping into the resources and the passion that and the momentum that's already been created, and really to promote health and wellness within the community.
People have talked about partnerships, but to us, partnerships are very important. They need to be genuine, they need to be trusting, they need to have longevity. I mean, these are the things that we do in order to build those so that you can do all the work that you need to do from there on. I think the glue is the fact that the Mayor's Health Task Force started with no money. And when you don't have money at the table and you just have people who are genuinely care and that they want to be able to capitalize or maximize efforts, they come together. And I think that's the one thing. Now, the alignment and synergy, it's important. So I have been very strategic, and we have really, the task force and the executive committee have been really helpful in creating positions and creating commitment from the city. So there's general fund committed to some of those positions. The other thing is our public health department, for instance, which is really in dire need of a restructuring. We are able to partner and actually say to the mayor, okay, this is the gaps. These are the gaps that exist in services, and these are the recommendations. And they put a pot of money set aside so that we can support our public health. So it's really, this is just an example. The Homelessness Initiatives Coordinator, it's partially funded by DON, partially funded by the city, really has been able to gather people at the table that typically don't come together to really look at root causes and system changes and policy changes. So these are some of the things. You gather people around issues like that. I am a Laurentian. I care. I have my kids there. I'm married. I have my family, my home there. I care about my community. So personally, that's what drives me. I try to get people to think and understand this is our community. This is not just the poor community. It's not the Latino community. This is everybody else's community. And then you need to communicate that and connect efforts. I mean, we just recently, someone talked about domestic violence. Domestic violence is one of the crimes in our city that's high. But nobody thinks about, okay, how is it connected to health? I helped hire a brand new community liaison person that's going to be working right at the police station, but with the community and the partners. This is just an example. You create linkages that make sense. You take advantage of the momentum, and you marry resources so that not only financial, but also like human capital. You marry them, you build capacity within your community, you'll get it done. So thanks.
Great linkages that make sense. Dr. Chen's slide said, and I want it, Alice, the one that struck terror in my heart was the one about the ICD-10 codes, where you're taking this subtle issue of relationship and converting it into transactional codes. We've got to stop thinking transactionally. This is not about the billing code. It's about the emotions and the feeling and the commitment that they all testify to. How you get there from here, I don't know, but that's your next question. So I'm going to ask you two questions. Do you want to comment before I go ahead? Okay, so I warned you in the phone calls I was going to ask these questions, but if you need to take a minute to think about it, just take a pass and we'll come back to you. But I'd like you to give advice about action now at two levels. If you're in this audience and you're in a city that, unlike Gardner or Lawrence, has not yet come together to forge the linkages that Vilma talked about, what's the first step? What would you say to someone in this room who says, I really want to get going on this now? What would action at the ground level? And the second question is to policy makers. We have some influential and caring legislators in the room. Policy is in the room. If you could change one thing about policy at the state level, or municipal maybe, what would it be? Now, I know your first answer would be money. So let's just take it as understood. You all need more resources, and we really do. And if you need to say it, say it. But beyond that, beyond the simple increasing budgets for this terrible burden, what else would matter in public policy change? So if you want a minute to think about that, you ready to? Okay, so advice to an actor in the room who's at a community level that hasn't gotten where you are yet, first step, and then second is a policymaker in the room. What could be progressive here to really help this get momentum and be sustainable, because the grants are going to go away. Sorry. Yeah. And how do we create peace in the Middle East?
Sure. Advice for the first. You're not alone. I think looking beyond our silo is the first largest step in knowing that you can't fix it by yourself in your one organization with the few staff that you have. Needing to open discussions and engage others is extremely important and one of the most difficult things to begin. And that's having people willing to have those open discussions about what are their weaknesses. Organizations don't want to admit that they can't do everything that they're assigned to do. So finding that safe place and those people with that same passion to begin a conversation is going to be the hardest thing. And getting them to the table without money will be that next hurdle, and that's where that passion again comes in. You're not alone. Find those willing to talk and begin the conversation. I think that's the biggest key.
You're not alone. I'm getting the hook here, so you get 1 minute each. So 30 seconds for policy, 30 seconds for community.
Okay. You know what, I'm going to pass for a second.
We'll come back to you, Mark. Make sure I get back to you again.
So the community one it's pretty easy actually. Just reach out to your partners and say, let's sit down. We think 2 + 2 = 5. The policy one, I sort of said this earlier, Massachusetts is moving this direction, but really from the behavioral health standpoint, some regulatory and fiscal billing regulation relief in behavioral health. So moving away from a unit rate volume-based service delivery model to more of a bundled payment and outcomes-based service delivery model, I think will help us a lot. Because as I said earlier, right now in our system, most of what we can do, you have to start with a full 60-minute diagnostic evaluation with families before they can do anything else. And that just doesn't lend itself to whether it's integrated behavioral health and primary care or in housing collaborations. We can't do anything with those families, and they're just not ready.
And the bundles have to be bigger than we usually think of as bundles, because you've got resources you need to reach to that we wouldn't normally put into house. Is that right?
Yeah, I would say around the community piece that, just have good communication and good relationships and rapport with the people that you're partnering with. I think that's, essential in establishing, your foundation to move forward with the work around policy. I would just encourage agencies to have a good vehicle for data collection. Because if you have the data to present to policymakers and legislators, that's going to really drive your target population and what you want to do.
So I would say addition and multiplication is better than division and subtraction. So, and honestly, it is better to, people are out there, and you just need to go find it. Everybody, I think, within their own organizations knows that this is really the future of healthcare in terms of addressing social determinants of health and figuring out ways in which you can partner better with your community and your community-based organizations. You just sort of have to open the door, and as people have said, get out of your own silos. And it is difficult to do at times, and it can feel scary. But once you meet up with those people, I think it gives you that much more feeling of connectedness and an ability to really impact people's lives. From a policy standpoint, I think I agree with the data that it's pretty significant, a need. And in access and timely access is probably a big piece, and of course financial is always an element.
Bill?
All right, so I think what's next for us, now that I'm in this role, I think it gives you an opportunity to look at things differently. And so since community development is about improving quality of life for people, I get to educate our local city councils on that, my fellow department heads on it. So I think that has to happen first, while at the same time we're looking for grant opportunities that complement the work that we're doing. For instance, the Green Community just provided about $600,000 to the city of Lawrence. We just became an age-friendly community, and guess what? We're applying for additional fundings for 3 years. So we're looking at planning, but also implementation. Guess what's in those domains that we're looking at? Everything else that everybody else is doing, that's what's there, and it makes sense. And so affordable housing is a major need for us. And so really from this chair and down, I'm looking at how can we look at what are some of the zoning ordinances, what are we doing to really create, I think right now, of all the new housing that has come up, about only 28% is affordable, truly affordable. Really changing the conversation about that. Youth leadership, we have a young community, so we really need to look into that. And so our Lawrence Youth Council that we implemented with GON funding, it's really training leaders, young leaders for the next generation. Employment, we have a high employment rate. So we are working more close with Valley Works and figure out ways, what are some of the barriers? What are some of the barriers that you have for those non-English speakers that are coming in looking for services? So it makes sense. From policy perspective, I think we're doing great. With the data piece, we're on track. We're part of the Mass Largest Cities effort that Department of Public Health is doing to get data to the census tract. And so we have someone at that table, and Lawrence is one of those communities. We're going to be able to get data down to the census tract. That's really important to us. But really looking at, I went to do a site visit with the Robert Wood Johnson Foundation. I'm part of the national board that does, identifies the new Culture of Health Prize winners. I can't disclose the city because they haven't announced it. But one thing that they do is they have within city council, they actually do training with the city councilors on what is health equity and social justice and racial equity. They do that, and all the work that they do, and you know what they're doing really neat? The money, the distribution, is not by district. They're looking at what are those census tracts that need the most money and really being distributing equally the funds to those communities. I think that's what I envision doing from now on.
Thanks, Mama. You used the phrase health and all policies for Lawrence. There's a WHO, World Health Organization guidance document on health and all policies. It's very, very important. And this kind of bridging Vilma talks about, we need to go to school on. Speaking of going to school, last word, Mark.
So I think I can't say what every community needs to do. I know for Gardner, it was about naming the problem. I think we have a system. We have a political system. There's systems that create inequities. There's systems that support privilege for many. And the people who are oftentimes in power, even in our local politics, are people of means. I know one of my stumbling blocks is typically my landlords, not my tenants, when it comes to getting money for the programs and services that we need. So I think I actually applaud the Department of Education, where they're focused on making sure that we're reaching our marginalized populations to try to help them. And then I just need the money to follow those towns and districts that need that support, and with students and children who need that support.
Thank you. Do we need to stop or good? Okay, so we get one question from the audience. I don't know what I did to earn that, but So does someone out there have something they'd like to ask this panel? It's an amazing panel. Yes.
So the question is, yeah, we talked about ACOs real quick. And we talked about funding, a need for changing funding system. Is the ACO system, do you anticipate making a change in any of these partnerships or how you do your work?
Will the ACO, the expansion of ACO work, change the partnerships in any way that you can think about?
So just in terms of looking at innovation funding through district dollars from the ACO, I think that that's really kind of our next step is looking at hotspotting in our community and figuring out ways in which we can use technology through some of that innovative funding. So I do think that the partnerships that we've created, it's only going to help us really address these social needs and really create that focus that we need to really impact specific areas that are really in high need.
There's some interesting work around expanding or changing the concept of ACO, where the C becomes community, not an organization, and that's something I would urge us to think about. And I go to England often. Not supposed to mention England, but I will. It's they now have something called integrated care systems that are exactly what we're talking about. Then they could talk about integration between schools or behavioral health at a community level. Maybe that's the next wave. Anyway, please join me in thanking this amazing panel.
Thank you to that incredible panel, and thank you, Dr. Berwick, for leading that great discussion. We're going to switch now to our last panel of the day, and we're a little bit behind time, so I'm just going to turn it over pretty quickly here to our moderator, Audrey Shelto, who is the president of the Blue Cross Blue Shield Foundation, and as her bio indicates, just an incredible leader in our community, her entire career, thinking about these issues for low-income and vulnerable populations. And the foundation has really stepped up and created an incredible leadership role in thinking about investing and providing grants and providing advocacy and research in this area. So we were so thrilled that she agreed to moderate this panel. I'm going to turn it over to her, and we're have such a great panel, but I do have to recognize one person on this panel who is here with us, Chairman Jeffrey Sanchez, the chairman of House Ways and Means. Thank you so much. I don't know what favor we cashed in to get you here today, but it was worth it. Thank you for your incredible leadership at the state level. Former chairman of the Public Health Committee, Healthcare Financing Committee, and someone who I know is just so passionate about the issues of the day. So with that, I'm going to turn it over to Audrey.
Thanks, David. I'm really thrilled and honored to be here, and we will try to talk fast and get right to the points here. I won't even let people introduce themselves. I'll just say, in addition to Chairman Sanchez, we also have Dr. Maisha Mitchell-Jordan, who, as you know, you probably know, is President and CEO of the Dimmick Center. Ellen Lawton, who's the co-director of the National Center for Medical Legal Partnerships at George Washington University, and Lauren Taylor, who you heard about earlier, who's the co-author of the American Healthcare Paradoxes at Harvard Business School and working in health policy and management. And we are thrilled to have all of you here. So we just heard about some really interesting examples in Massachusetts of partnerships around trying to address social determinants of health. But I thought maybe to get grounded on this panel where we're going to shift gears to policy issues, could one or two of you just very briefly give me an example of some innovative model you've seen that you're excited about related to addressing social determinants? Ellen?
Uncomfortably close. Okay. Hi everybody. This has been an amazing morning, and I'm here actually to channel an amazing model that was birthed here, literally in Boston, and is being replicated nationally. So Samantha Morton's at the head of that with the Dulce Project, which is focused on early childhood supports or concrete supports for families, focused on social determinants and includes a legal component there. And so that is showing some real outcomes. And it's an example, I think, of where it's something that's been innovated here in Boston and is being replicated in a variety of settings. And that's what I'm excited to talk about this morning. Great. Is like what's happening. Some of it started here, what it looks like out across the country.
Just to whet your palate in terms of, I think, some of the boldest and in some ways most controversial social determinants of health efforts. Out in Portland, Oregon, you have 6 coordinated care organizations, which are their version of our ACOs, who have actually put in $21.5 million to actually build new affordable housing in the city that has an enormous homelessness problem. And so, you know, we can talk more, and I hope we do, and interrogate whether or not we think that is really appropriately the role for healthcare. I think some people think, yes, let's see them rush in, put some resources towards it. I myself have some real equity concerns. You know, I think private, for-profit or nonprofit healthcare organizations can have different priorities for where to put housing and how to allocate scarce public dollars, but I think that's something that always comes back to me as kind of the leading edge of healthcare's involvement in this space.
So I'd just like to, as a community health center leader, I don't think I could sit here without saying community health centers. And it's really interesting because I sat with someone, an incredible professor in public health, and described the model of what we do at DIMIC, and he said, well, how long has this model been around for? And I said, since the 60s. So when I hear organizations that are bringing together community health workers, figuring out how do we integrate behavioral health and substance use disorder, how do we think about residential programs, how do we think about inpatient detox services and connecting those patients into primary care, how do we think about early childhood and the impact of healthcare in early childhood, I think of the DIMIC Center. So I just want to make sure that as we think about these incredible models all around the world and all around the country, that we don't forget about what's actually here. It started here in Massachusetts, and the reason that community health centers were started was to incorporate all of these social determinants of health that have now become what we talk about today, what was recognized back in the 60s.
Yeah, I think that's a really good point. I was so glad that Dr. Chen brought that up earlier. When I first started getting involved in the whole issue of social determinants of health, that was the first thing that came to mind with me was like community health centers. They've been doing this forever. But to the importance of our panel, not with the policy supports necessarily to really advance that work. So I think that's what we want to focus on today. So just at a broad level, what do you all see as some of the policy changes that we're going to need in order to support these efforts that we heard about in Massachusetts and some of the more innovative work that you're all excited about?
Going down the line?
Yep, we can start down there with you, Ellen.
Well, I think, first of all, I want to elevate everything that the previous panel said, because they talked a lot about policy changes that need to happen in order to bring us closer together, and then also to pay for us to have conversations, right? That's a lot of what you heard from the previous panel, and certainly what I see around the country, and through the medical legal partnership lens, but more broadly through social determinants of health interventions, is we need time and space and money to bring us together to have the conversations and bust out of the silos. So that's a policy change.
So how do we change that?
So the value-based shift to value-based care. I know that some of the people in this room are thinking about risk adjustment frames that will put a priority on how to focus resources more directly into high-need populations, not on soft money, but on hard money, as they say. So I think those are policy changes that need to be effected in terms of health financing. But separately, and again, I know there are some leaders in this room, they're thinking about this all the time, and I just shout out to Megan Sandel, who's done amazing work on housing, is how are we paying for some of these social determinants of health that are so bedeviling us on the healthcare side, and shifting those resources around. I think that one of the things I'll say, and I'd love to chat about more, is that what we see is that highly under-resourced settings, like we heard about in Lawrence, but now I'm talking about Montana, Alaska, places where they're doing some really amazing collaborating because the resources are so thin. and they're forced into collaboration. And now how do we help them to sustain those collaborations through different mechanisms of financing, but also sort of a more collaborative approach to planning.
Down the line. Okay. So policy changes that could be helpful. I'll throw out two that are non-financial, and then one, of course, I have to say something about money. So the two that I think could be facilitative, one would be not necessarily a change, but maybe some further guidance from something like the AG's office, maybe even HPC around HIPAA, because so much of this work is going to require collaboration between the healthcare sector and community-based organizations and health centers that have different understandings of patient privacy and different codes of ethics about how they handle information. And HIPAA just seems to continually come up. In some cases, I think it's just a smokescreen for people not wanting to do the hard work. But and I have seen, especially in the CHART program and others, it can be worked through and it can be worked around. It is not nearly the barrier that I think we make it out to be. And so having some lawyers come out and say, here's how to think about HIPAA in the context of working between health and social service sectors would be quite helpful. A second kind of non-financial policy would be some forms of technical assistance, I think, to community-based organizations. Again, I'm focusing on these community-based organizations because they have been the ones at the front lines doing social service work and addressing social determinants of health forever. And so the idea that healthcare has to suddenly come up with ways to address social determinants of health like out of thin air feels quite silly when we have an entire sector that has years and decades of know-how. And yet the CBO sector in many cases is locked out of or just not quite well informed or brought along in terms of what's happening in health policy, and certainly in the state here, I think with Mass Health and the redesign, in talking to CBOs, they just say, we feel like we're not at the table, we can't quite figure out what's going on. I mean, I can't quite figure out what's going on, so maybe that's not distance from the issue, but some targeted efforts, in New York, they underwent a similar Medicaid redesign, and they held specific boot camps. So they were called value-based payment boot camps, and they invited the community-based organizations, the social service delivery sector, and they said, come in and learn about what we're trying to do, what the metrics are that your potential partners are going to be beholden to, that kind of thing. And then the third, which is financial, I would just say, flexible dollars are what's needed. So the issue is that I think even the best intentioned healthcare organizations right now are so under the gun. The word in health policy right now is accountability. And so for that to be the word of the moment and for us to be asking them to take, in many cases, huge leaps of faith to go out and partner with an entirely new sector that they historically had really little insight into, they don't understand the business model, is really asking them to do a lot at the same time. And so I'm really empathetic, as much as I think I can be quite critical of healthcare. I'm also empathetic that the policy environment now is not really hospitable to an enormous amount of experimentation when it comes to social determinant health programming. They've got metrics to meet, they've got a lot of regulatory kind of constraints on them. So if we were to actually be able to find some dollars that were here, experiment with this. We know some things will not work. We know some things will not bring down readmissions, et cetera. I think that could really free up different kinds of relationships and partnerships between healthcare and CBOs.
Great, thanks. We'll come back to the issue of culture, which I think is so important here. But just to quickly comment on your issue around privacy, we found in the work that we did at the foundation that even when you're trying to integrate behavioral health and primary care, so you're still really in the healthcare medical world, there's all these sort of realities and myths around information sharing. So when I think about, and when I'm talking to people about trying to integrate housing and food programs or trying to figure out who in the public housing programs is receiving Mass Health benefits, there are so many barriers, real or perceived, to getting that basic data that all of you talked about as being so critical to doing your work together.
Can I bust in? Yeah. I just want to lift off on that comment a little bit because, I'm trained as a lawyer, so when you're a hammer, everything's a nail. So like what Lauren said about the legal profession, that's what we're all about, is getting the legal profession to be on board talking about social determinants beyond a policy way or on the front line. So show of hands for lawyers in the audience. How many lawyers we got? Okay, all right, fair enough. But that's part of this, because you're not going to make some of these policy changes, whether it's on the SDOH side or the financing side, without lawyers really being part of that process,
understanding it and partnering on the CBO side, but also inside of healthcare. So just something to think about in terms of policy.
Chairman Sanchez, I caught you when you're sipping your coffee. I'm sorry. I apologize.
I guess, when I'm around you, Dr. Jordan, Dr. Taylor, and Vilma, I just know just to shut up and listen. So, oh, and Representative Barber. By the way, give her a round of applause because we spent a lot of time talking about making sure that we kept working poor in Mass Health. And these are the questions as we talk about policy that all of us are going to have to tackle. In the beginning, I feel like we're in a Star Wars, like not the trilogy, but whatever comes after. Like this is a saga. The road to coverage. Remember how that's like embedded in all of our brains. But beyond that, 224 created this. The opportunity for us to talk about where we're at, where we're going to focus into the future. And for me, the work, frankly, the Dr. Minta Jordan and the Vilma do every single day where it matters. When I see Vilma sitting down with community-based organization, church leaders, people that are on the street, and I see what's happening over at Dimmick on a day-to-day basis where there is a lot of that and a lot of things that, thank God, none of us ever have to see. But she sees and she has to treat. And in that, we're going to have some serious conversations because remember, here in Massachusetts, yeah, Montana, yeah, Alaska, but frankly, there is no place like Massachusetts. And how do you know? Look at the budget. 43% of a $40 billion budget is focused on healthcare. It is huge. For me, I've said it before, it is the largest investment that we make in it is the largest economic development initiative that we have every single day, and all of you are part of that. So for me, I want to see what else we're going to come up with, because although we've been able to deal with a number of things directly, either through reimbursement, and we've also done things relative to make sure that there's extra money that I see Maddie Ribble here on Prevention and Wellness Trust, of which the Public Health Association was a pretty big force. Where do these things fit in this new dialogue now that we have a program like Mass Health, that it is the only program in the nation that is calling for pure integration of services? And within that, we find the innovation that's happening with the community health centers through that C3 initiative, where the community health centers are saying, okay, we're going to wrap all of our population together and we're going to figure out how we're going to work in a very cohesive manner, because we know where our people live and we know what are the determinants that are affecting their well-being every single day.
So just before I turn to Dr. Jordan, Maisha Jordan, I think most of you know C3 is one of the new ACOs that is formed by community health centers, and it's a community health center based ACO. Just want to make sure you knew that. But
No,
Maisha, I'm sure you go ahead.
Founding members. So I think as we talk about going back to your first question around innovation, and I start off with community health centers, but I think it's important to think about C3. We are the only community health center driven ACO in the country, first of its kind, and I think we're close to the largest ACO in the state. So as we think about innovation, if this is community health centers saying, give me your dirty laundry, there are 4 of us that sit around the table, tell me how your quality is, tell me what your infrastructure looks like. Can we really do this and prove to the state that we can lift up this company within a year or 2 and take on risk? And we've done that, and we're moving forward with that. And as we think about the regulatory barriers that are inherent in creating this kind of model, one is 42 CFR, which you alluded to, because as we're thinking about how do we integrate behavioral health, and some health centers have done it more than others, the barriers around sharing data, even within our Mass Health population, to be able to really practice population health is incredible. The other piece to that is, as we're thinking about the funding and using, how do we use our infrastructure dollars to be able to support the transformation that we need to create, we're having other levers pulled at the same time. So our 340B, our pharmacy funding, is being taken away in part. So what we need is the ability to focus in on this new initiative without other levers being pulled at the same time, because we're now having to respond to changes in behavioral health rates, changes in 340B pharmacy, changes within our mass health population. And entities can only do this work if we have the support of government leaders like Congressman, that's coming. Chairman said,
I'm gonna open a burrito joint.
President.
You heard it here first.
I'm putting it out there, but we need leaders who understand and can listen to us and hear these concerns in order to move this forward.
So I think, you've all stated various things that, in order to support the delivery system reforms that we're trying to achieve here, which are so significant, we obviously are going to need payment reforms to go along with it. Just to shortcut that conversation, since we could go on for hours about that, I think that's a sort of a necessary but not sufficient issue that needs to be changed, and that the state is really taking a lead on in terms of the 1115 waiver and the ACO transition. So really excited to have that platform. But Lauren, let me go back to the issue of culture that you mentioned. I know you've done some interesting work. Even in the original book, I loved your early chapters about the history and the cultures of the medical community and the social service community and how they're so different. And and I heard, with several of the programs in Massachusetts talking about, how do you reach out and develop these partnerships? I mean, how do you start working together when you've been operating in totally different worlds? Could you just say a little bit more about what you've looked at with that, and then anyone else can chime in?
Sure. So I think, I think about management, and so one of the most glaring differences in the culture of healthcare organizations and community-based organizations to me is what they consider to be good management or good quality services. And so if we think about healthcare, what makes for good quality healthcare? Generally, we think it's something about standardization and replication and ability to know every patient that walks through the door with psoriasis gets the same workup, and I'm going through kind of the same decision tree to make sure that I'm figuring out what to prescribe or advise. When I talk to community-based organizations, that's not at all how I hear them think about the quality of the services they deliver. So when I ask CBOs, what makes you feel like you're doing a good job? They say something like, well, it's the way in which I can respond and my team can respond to how different every child is and how different every family is. And so it's something about adaptability and meeting people where they're at. And so my sense is that as we think about increasing the number of partnerships that happen between these two sectors, that's going to be a real point of initial friction, because CBOs are going to look at healthcare and say, how naive of you to think that a one-size-fits-all approach is going to work for this really complicated population that I've been serving. And healthcare is going to look at CBOs and say, you're terrible at record keeping, you don't have any standardization, how can you expect me to bill for this? And I think it's just important to recognize that there are dissident voices on both sides, right? There's always kind of a cadre of hippie doctors who are talking about the craft of medicine and the good old days of country doctors. And they're always trying to remind us that maybe there are things that we can't fully standardize and put into a protocol or a checklist. And there are certainly people in the CBO world who are saying, look, we do have to, I think, come up with some better record keeping systems, and we do need to maybe keep a closer eye on what the different costs or units of care are. So ultimately, I think the reality is, of course, good care, whether it's health or social services, requires both, but this is yet another place where I think some technical assistance or even facilitative assistance, bringing these partnerships together, could be really helpful, because if we're not calling this out and helping people to recognize this in one another, I think it could be something that people cut the cord and walk away much too soon.
I just want to make a quick comment. I think a lot of it is also leadership, having really strong leaders who can identify an issue and find common ground. So as an example, Urban Edge owns about 1,100 units right in Roxbury. DIMIC sits in the middle of that. And the president at the time came and said, you're seeing our patients, we want to be able to keep people within our housing units. We don't want the turns, we want to make sure that people can stabilize within the housing complex. And so we came together to say, well, how can we make sure that we're creating affiliation that keeps people in their homes, which meets your need and your business needs, and also drives some volume to DIMIC, which we have the access, we have the expertise to be able to provide, and it's only going to be a win-win situation. So I think it's aligning sort of that, there's a business case to all of this. And I think we don't talk about that enough. We're saying that we're addressing these issues so that we can keep people healthy, that will then bring costs out of the system. And so I think really being able to establish that, and then having leaders who believe in that and believe in the mission work, understand the business case, and then can drive it throughout the rest of the organization. And sitting down to be able to do that together is really incredibly helpful and beneficial to both of us, and we've been able to move that forward and continually seek funding to help support some of those activities.
And I think that's really, really critical. Chairman Sanchez, that leads me to thinking about you and your new role, relatively new role of managing this huge budget for the state. And obviously, you know, when I know, I shouldn't say obviously, I know when I work with folks from Mass Health or even commercial insurers, but mostly from Mass Health, there's a lot of, you know, interest, as we're all talking about today, in addressing social determinants of health, but there's also real concern about, is there a business case here? You know, and I'm sure in your role, you have to think about that in terms of new initiatives.
I think we've all, again, the conversation's been out there for a little bit, and I think you're seeing the product of that in this, I'll say particularly in the Mass Health integration that's happening right now. We, the legislature, with the administration, agreed that community had to be built into everything. And that wasn't necessarily the model. That wasn't necessarily the way that folks work. And one thing that I learned in my own district, because, you know, where Dr. Mincha Jordan works every single day, she's got the urban housing, the urban edge housing that she's within, but there's also maybe 3-4 housing developments that are around her as well. So for her to be able to have a reciprocal relationship with community-based organizations in delivering care is really important, because there's a lot of folks that live in these places that are really isolated. It is real. There are people that are really isolated in their communities, and nobody knows who they are, what their needs are, but we do see them 2 or 3 times in the emergency room. And we do see their family members that are suffering from other ailments or from other issues. So we're having those conversations and we're putting it to the test. So while we're here, I want everybody to realize this work is happening, and it's happening because all of us have been communicating with each other in a really, really meaningful way. The question is, for me, how do we, because there's this bigger conversation, you know, growth is relatively stabilized, Washington is crazy. When people start talking about bending the curve, what does bending the curve really mean to all of us? I mean, that's people that are providing and helping people on a day-to-day basis. And I have to do one thing. I have to make sure that we pass a balanced budget and that it touches everyone here in the Commonwealth for the common good, and that we do it in a fiscally responsible way. We have to have these conversations. How do you bend the curve, but at the same time make the difference? And that's where I'm going to be depending on her, Vilma, who just left, Audrey, and so many of you to help me think about this, because I've devoted my life to public health and healthcare for a long time, and I feel like I'm in a really unique position right now in this role of Ways and Means, especially since the budget is so big. And the House budget I felt was very strong in these areas. The question is, how do we make sure that it's sustainable and making a difference?
Ellen?
So yeah, that's a very inspirational, right? That we have this opportunity, but I also think that for the sustainability facet of it, back to Lauren's point about how are the professions thinking about their work differently, because we overcame all of our own individual silos to have a conversation about what needs to happen, and the innovations in payment delivery and system reform here that lead the nation, no question about it. But to sustain it, we have to practice differently. So when I think about policy, I also think about policy small p, which is what is the Massachusetts Bar Association, the Boston Bar Association doing about the HIPAA problem that Lauren identified, because that's real. That we are not sharing information, we don't feel like we can share information, and so those barriers are going to persist unless we undertake through medicine and also through law, how can we break that down as a professional strategy? Because lawyers are not trained as team players. right? So we're just not, and we have a lot to learn from healthcare about how to be team players. And healthcare teaches us a lot about innovation. It teaches us a lot about planning. It teaches us a lot about leadership. And so we have lots to learn, and they have a lot to learn from us. And so sustaining those conversations in an integrated way, depending on Representative Sanchez to make that happen from a financial perspective. But we have an obligation, given our leadership in the academic world and the next generation that we're training every single day, to train our professionals and our paraprofessionals to look different.
I just want to jump back in on this business case idea, because I think it's really important that we are precise in how we talk about the business case. And many people want to just say there is a business case because, of course, that makes things sound potentially more sustainable than they actually are. There are at least two different kinds of business cases here. And I think when we all go back to our lives and think about how to make the business case, we should be clear on which one we're making. One is the business case to healthcare, right? And that's a business case where you're saying, I think making this social determinant of health investment will bring down the total cost of care of healthcare utilization in some way. And therefore it is in the business interest of whoever holds the financial risk, the payer or the ACO or the MCO. There is another business case, which is it's in the interest of society, right? It's in the interest of government potentially to make this investment. And those may be social determinants of health that improve the health status of our children or anyone in society, but they may not dramatically or statistically significantly impact the total cost of care or utilization. And in fact, when we engage certain populations that have been historically very underserved, their total cost of care may go up, at least in the near term. And so I think it's just really, really important to be clear that those are not always moving together. There can be things that are not in the business interest, or the business case is not there for healthcare to do it, but there is a business case for someone to be doing it, either in the public health sector or in the CBO sector. There are also things that may not have a business case at all, but are worth doing because it is the morally right and just thing to do. And so those are three different ways, I think, of justifying and thinking about the value of social determinants of health investments. And if we're lazy in how we kind of conflate those things, I think we lose credibility because people just won't trust us the next time we say, look, there's a business case for this thing. Very good point.
Just to add to that, and I totally agree, where we are now with the Mass Health ACOs is clearly in the former. So we're looking at total cost of care, and as we're bringing together Medicaid populations across 17 community health centers, is how, and this is a shift in framing for community health center leaders to think about this, because we had really just been thinking about our own population, our own budget, how do we sort of scrimp and save and rob Peter to pay Paul to keep these programs running. And now we're thinking about standardizing care models across 17 community health centers spread geographically throughout Massachusetts in a way that we haven't done before. And then also looking at total cost of care. Everything that we do is being monitored in that way. So it's a different shift for us. And just also on your note, part of what I've started to do within the last year, call a lawyer if I have an issue with the behavioral health regulation. I've called Healthcare for All to think about how do I make sure I'm advocating for Medicaid patients so that they understand this new model. I've called, Jeff all the time to say, what do you think about this? And can we do this? And our chairman has been amazing in advocating for community health centers historically. And so all of these pieces are coming together in a very different way as a community health center, thinking about our population to say, I have to engage all of these different facets and really think outside of my usual world. I've also called a lot of our academic partners. Our C3 is partnering with MIT to evaluate our model. We're partnering with other academic institutions. So it's a very different way of thinking about public health, understanding that we can't just do it within the community health center model. We need to really pull on all of these levers.
Yeah, so I would think one way to summarize this panel is just to acknowledge that the policy issues related to addressing social determinants are many and they are complex. We've talked about things like privacy, delivery system reform, payment reform, dealing with different cultures, dealing with education, thinking about how do you go back further upstream and how do people become more knowledgeable about the different sectors and about team playing, when that's not what you're trained to do. New workforce areas like community health workers and peer recovery coaches. there's so many issues, but I think the thing that really inspires me, and has for the past couple of years while the foundation's been working on this, is I don't remember 5 years ago that we would have rooms full of people like this. I was in rooms with healthcare people, and I have met and started working over the past several years, as all of you are describing, with people from so many different sectors and from municipalities and from communities. And it is, I think, by working together and crossing all of our own silos that we're going to get this done. So this has, for me, been a really inspiring conversation, and I will turn it over to David to close.
Well, thank you. I think we're going to wrap this up right on time. I just want to say this has really just been a tremendous event. I want to thank everyone for coming to this event this morning. And I just want to recognize all of the speakers that we had this morning, as well as all the panelists. It was just really a tremendous group of individuals providing incredible perspective. So I don't know, I hope you feel as inspired as I do by this conversation. I would just want to close and say, at the Health Policy Commission, our goal is better health, better care at a lower cost across the Commonwealth. And if you share this goal and you want to work toward this goal, we are eager to partner with you too. So please connect with us and work with us and help us. And we want to learn from you and work with you and support you. So thank you so much for being here this morning. Thank you to this incredible panel, and have a wonderful day. Thank you.